The following episode is brought to you by the American Urological Association.
Good morning. My name is Jay Rahman, and I'm professor of urology at Penn State Health and chair of the AUA's Office of Education. It's my pleasure to host another episode in our educational podcast series, with this specific episode being one of several that we are doing to highlight either new guidelines or guidelines that have been recently amended. And I would certainly say that these are often amongst our most popular podcasts that we do, particularly as we get towards a lot of the standardized exams and a lot of the certification or recertification process. It's really my pleasure for this podcast to be focusing on the topic of the diagnosis and treatment of infertility in men. And joining me today is Dr. Bob Brannigan. Dr. Brannigan was the chair of the amendment panel for this guideline. He is at Northwestern, and he serves as the Janice Binstein Professor of Urology and Vice Chair of Clinical Urology at Northwestern. And he's also the director of the Andrology Fellowship. Bob, first of all, thank you in advance. Always good to, as I said, it was good to see you last month in person. Nice to catch up with you again on virtual. And thanks again for, about 30 to 40 minutes of your time this morning.
Great. Thank you so much. Really appreciate the opportunity. I want to thank you in the AUA Office of Education, not only for this podcast, but more broadly supporting the guidelines process. I think that the AUA is head and shoulders above other professional organizations in providing its members with roadmaps and how to provide really evidence-based care for our patients. So thank you.
So Bob, before maybe we dive into maybe some of the amendment changes, just give us the big picture view. What's the rationale for the original guideline back in 2021? What's maybe some of the rationale, and what was some of the new literature that came out that you all reviewed as part of the amendment? Just give us a perspective of that as a starting point.
Yeah, so first of all, tip of the cap to the inaugural version of the guidelines, which were spearheaded by Dr. Peter Schlegel from New York, who did a wonderful job with his, the colleagues on the panel at developing this inaugural version. And just want to say thank you to Corey Tannerkut and Senate Kim with the AUA for helping us to provide this updated version or the amendment. The amendment really covered the 4 years of literature from 2019 to August of 2023, the new literature that had been published since the inaugural version. And there were over 4,000 new studies that came into consideration. So I think just evidence that our field is one where there's a rapid proliferation of literature and information. And I think, the AUA just wants to make sure that we're staying laser focused with being current with our familiarity with the literature and also with our patient care, kind of being on target with that.
No, that's super. I think it's always, I think one of the things that the AUA does quite well, and I think you alluded to it, is that, look, the literature changes, there's new studies, there's new findings, and I think that it's really incumbent for these guidelines to be relevant, to be revisited, even if maybe the changes are limited or in some cases more extensively so. So maybe before we really dive into some of the nuances of the guideline, I think it really would help our listeners to first kind of get a sense of when we talk about a semen analysis, and I think, semen analyses are probably germane to many practices, even if you don't focus specifically in the realm of infertility or male sexual dysfunction. But talk to us about, with regards to semen analyses, the terms, what are the terms that we see in these reports? What do they mean exactly? And then maybe we'll start talking with that in hand about the next component, which is, reference ranges and things that sort of jump out to you.
Yeah. So just brief statement before hopping into the terms is that, 15% of couples in the United States grapple with infertility. I think a lot of providers, a lot of urologists think of infertility as only being if there's been a year that's passed from the time a couple has tried to conceive. And there's been an update there. So if the female partner is 35 years or older, after 6 months, we should begin a workup if they have not yet conceived a pregnancy in that time frame. So some important points and some pretty big change that I think a lot of urologists are not familiar with. And so, yes, one other point is that, we don't wait until the female partner's workup is completed before working up the male partner. The guidelines state that about half of couples have a male factor issue present. And very often we can improve the couple's overall fertility in a much less invasive way by evaluating, treating the male partner than, again, having the burden for reproductive diagnostics and therapeutics repetitively fall on the female partner. And that's just been the long history of reproductive care globally. And, I think the guidelines call this out and just say, hey, let's evaluate the male and female partner first. This is what is most practical and most common sense for the couple and really the best medicine. So the semen analysis, it really is the bedrock of fertility testing, as you alluded to. And I remember being a resident and the first, educational conference on male reproduction, and it was just a little bit blurry. I mean, the terminology really got in the way. We're talking about aspermia, oligospermia, teratosospermia, and those can be really foreign terms. And again, it's unfortunate because the concepts are really not at all complicated. So with this new edition, we added Table 1, which is just kind of a roadmap to some common terms that we use. So aspermia, that just means the complete absence of semen. So patient ejaculates and nothing comes out. Azoospermia, in contrast, there's semen coming out, but there's no sperm in the semen. Oligospermia is a low sperm count, and that'd be less than 15 million sperm per milliliter concentration. Asthenospermia really refers to lower motility than the reference range. And teratospermia refers to abnormally shaped sperm, so a lower percentage of sperm normal shape than the reference range, and that's typically going to be 4%.
So one sort of just maybe a few practical questions as you've sort of given us some of the basic definitions. And I think those are always helpful because I certainly think, sometimes it gets to be a little bit of a word salad. And I think it's really great that there's this table that sort of defines what these different terms mean. But maybe just one or two practical questions before we talk about like what's normal and what's abnormal on these. Can you, is there a certain number of semen analyses that you should obtain in a patient? Like, is one semen analysis enough to make this assessment, or is best practice to have multiple so that you're not maybe basing all your decisions on a single one? Maybe just tell us about that first.
So, this is a really important point, and I think the guidelines are a little bit broad here, and that broadness is really based on the literature. So I'd say that the guidance is at least one semen analysis in the male partner. As a practice, I think most people that do a lot of this kind of work obtain 2 tests because of the pretty high degree of variation of parameters, even within a short period of time. And you want to know about that because that can really steer couples in one direction towards natural conception. If they're kind of, borderline with sperm concentration, but then oscillating between that and higher counts, maybe they have a longer period of time of trying by natural conception. Whereas if they're borderline and then maybe subsequent samples are lower, maybe that's going to be steering a couple towards insemination or assisted reproductive techniques.
So maybe 2 other related questions just on just sort of the mechanism and the ergonomics of checking semen analyses. I think that I think we know more and more that, for example, if you check a serum testosterone, that's best to be done early in the day. So is there a particular time of the day, first of all, that it matters for semen analyses, number one, and number two, maybe in your practice, maybe there's no guideline statement, but in your practice, is there a certain number of days that you would have wanted from prior ejaculate so that you're getting, I don't know, maybe the most representative sample? And maybe there's not something in the guideline, but maybe talk to us about your own practice and what you do.
So the optimal days of abstinence before semen testing is really 2 to 5 days. And I personally think that 2 to 3 days really is best. And the reason for that is we know from an abundance of studies, including landmark studies going back to the 1990s, that the highest frequency of pregnancy occurs when couples engage in intercourse every other day around the time of ovulation or in advance of ovulation. And so by getting semen testing every 2 or 3 days, you're really going to have a good idea of what their semen parameters are leading into each episode of intercourse.
So that's great. Very helpful, very practical. So tell us a little bit about what are sort of the reference ranges, and have they changed, and who do we use, or what sort of criterion panel do we use when we're defining, what is normal and what is abnormal? Talk to us about that.
So some really important points here. So the World Health Organization did update their reference ranges. The 5th edition of the WHO Semen Reference Guidelines or Guidance was published in 2010, and then the more recent 6th edition published in 2021 after our inaugural version of the AUA Infertility Guidelines. And there were not earth-shattering changes. The reference range for semen volume went from 1.5 milliliters or higher to 1.4, so a little bit of a shift up. The motility shifted from 40% up to 42%. So I think it's important to be aware of this guidance, these reference range. But I think the bigger point is that, these semen analysis reference ranges are not lines in the sand that divide men neatly into couples, or I should say into categories of being fertile or infertile. In fact, I think a lot of urologists are simply unfamiliar with the fact that the WHO generated these reference ranges without considering any infertile men. Mm-hmm. What they did is look globally at men and looked at semen parameters and then drew a line with each parameter at the lowest 5th centile, and that was the line of demarcation. Mm-hmm. With less than that 5th centile measurement as being abnormal. So again, no infertile men were considered in the generation of these reference ranges. In fact, every man that was part of the study had proven fertility in a year or less. So I think what we see in clinical practice is that there's a big overlap between men with normal semen parameters who have difficulty conceiving and men with abnormally low semen parameters who just seem to be able to conceive without too much difficulty. So a big overlap there. And it's important for us to message to our patients that these are not lines in the sand, these reference ranges. They're helpful, but they're not lines in the sand dividing couples into fertile and infertile.
No, that's great. That's really helpful. So I'm going to go back, and I don't remember a lot of this, so I'm glad you're going to be able to educate me. But I remember many years ago, obviously training at Cornell, and we had a big infertility center, and one of the big themes, even 20 plus years ago, was karyotype analysis and some of the mutational profile. So maybe just talk to us and talk to our listeners and myself a little bit about when do we do that? Maybe what are the big names and the big ticket items? I know like Y chromosome microdeletion comes up, but maybe talk to us. When do we get that? What are the more common types? And then maybe what is changed in the literature as all of you have reviewed the guidelines and the data for the amendment?
So for the longest time, 5 million sperm concentration or less was the cut point to initiate genetics testing, namely Y chromosome microdeletion testing and karyotype testing. And, there have been some developments in the literature, just looking more specifically at the utility of Y chromosome microdeletion testing. So if men have sperm concentrations between 0 and 1 million sperm per milliliter, about 5% of those patients will have Y chromosome microdeletions. And so definitely worth testing those individuals. What we found, though, within this updated amendment was that for men who have sperm concentrations between 1 million and 5 million, the positivity rate for Y chromosome microdeletions is only 0.8%. And so for that reason, we want to be thoughtful about how we're appropriating our testing and our resources. So we move the reference range down So now if men have 1 million sperm concentration or less, that's the indication to pursue Y chromosome microdeletion testing.
Okay.
Now, if we look at karyotype testing, that's still, still the bar is set at 5 million sperm concentration per milliliter or less. Still do karyotype testing in that setting. And of course, the most common karyotype abnormality is Klinefelter syndrome, which is really prevalent, affecting about 1 in every 500 to 600 males.
So, Bob, that really helpful to know that. It's really nice to know that there was some thought put into based on the how often you see an abnormality about changing those thresholds. What you did mention to us is it sounds like it's number of sperm count per million, right? Is that, or per milliliter? Is that
per milliliter? Yeah.
Per milliliter.
Sperm concentration, yes.
Is there and is it strictly a concentration count number, or what if you are at, I don't know, over 5 million, but you had some other morphologic changes or motility? Do those play in at all, or is the criteria really just based on concentration?
I think the guidelines do provide leeway always for clinical judgment and the provider looking at a patient and initiating testing on an individual basis. But it'd be pretty uncommon to have an indication outside of sperm concentration to pursue Y chromosome microdeletion testing. Now, on the other hand, again, Klinefelter syndrome is very prevalent, and while most patients affected by that condition are going to have low sperm concentration, the vast majority will, but not all. And so, in that instance, though, if you suspect, perhaps based on phenotype or the endocrine profile, that there's something going on, certainly a karyotype test is easy enough to do. It's a blood test, and we provide some clarity in an otherwise murky situation.
And then maybe just for our listeners, maybe just give us a little bit of it. So number one, how do you assess for Y chromosome microdeletion? And then maybe just talk to us from your background and expertise, the different types, and without diving, into all the nuances of a detailed infertility practice, what do the different mutations mean for you? Because I do feel like that does come up as we look at the different mutations, that certain ones should really clue us in or mean more specifically with regards to future fertility. Maybe talk to us about that a little bit.
Important point. And again, I think for urologists, sometimes this can get a little bit unclear. And I think we'll be able to provide some real clarity here in just a couple of brief statements. So the Y chromosome is the male chromosome. As we review, the short arm of the Y chromosome houses the genes that code for sex, the sex-determining region of the Y chromosome. It's the long arm of the Y chromosome, the Q arm, where the genes that code for sperm production are located. And so there's this region of genes called the AZF region of genes that code for sperm production. And this area is really broken up into 3 regions: AZF-A, AZF-B, and AZF-C. And the testing is really important because if a patient is missing all of AZF-A or all of AZF-B, we know just from a long history of literature that those patients will not have spermatogenesis present. So we do not offer a microtesting to those patients. If, on the other hand, a patient has an AZF-C microdeletion, about half the time they'll have sperm present on microtesting, even though they're azospermic. So, this testing is really helpful and can provide us with clear guidance on whether or not to go to the OR. And again, if the patient has an AZF-C microdeletion, we can prognosticate to the patient. You got about a 50% chance of us finding sperm on microtesting.
Great. No, that's really helpful to sort of put into context the implications of not only, as you alluded to, the thresholds for doing the testing, but then importantly, the implications of the different types of mutations. So let's maybe shift over a little bit and talk about imaging and how imaging has changed. And I feel like this is one of those areas almost ubiquitously in our field, right, where imaging is constantly changing. And if we just think about, for example, prostate cancer and diagnostics in prostate cancer, the concept of pelvic and prostate MRI has really been a game changer with regards to diagnosis, identification of prostate malignancy. But I suspect that you probably and persons are probably using similarly this to get a better refinement and visualization for certain specific conditions pertaining to male fertility. So talk to us a little bit about that. When would you use prostate imaging? What imaging do you use? And what information are you trying to get from it?
Well, really glad that we can talk about this particular statement. This is another aspect of the guidelines amendment that we're really proud of. I mean, there's been a lot of movement within our field looking at imaging and how we can leverage it to provide best outcomes and best patient care in least invasive means possible. And I would just say, looking back over the course of my career, looking at all the folks that have kind of, really looked at the application of imaging, even going back to Marty Resnick quite a while ago when I was in training and early in my career. And I think, if he were here now to see a lot of these advances across urology, he'd be very happy and proud. So specifically regarding fertility, if we see men that have low ejaculate volume, azoospermia, and especially if you have the information that their pH is acidic, that is going to suggest a strong possibility that they have either ejaculatory duct obstruction, or alternatively, these patients could have congenital bilateral absence of the vas deferens. So, usually congenital bilateral absence of the vas deferens is right there. Physical exam, you examine the patient. Most commonly, they're missing the vas deferens bilaterally, and they're missing the distal 2/3 of the epididymis bilaterally. So pretty easy to figure out who those patients are usually. There's a small caveat there, though. Sometimes the only manifestation of that condition is points of obstruction in the epididymis. So don't want to get too much into the weeds on that for the purposes of today, but CBAVD is one group that could have low ejaculate volume azoospermia. The other group are patients that have a blockage of the ejaculatory duct. And so historically, the way to figure that out would be to offer the patient transrectal ultrasound and image the prostate, looking for typically midline cysts, although there can be perimedian cysts that cause ejaculatory duct obstruction. And then at the time of transrectal ultrasound, very often we could also measure the seminal vesicles. And if they are abnormally dilated, put a needle in and aspirate the seminal vesicles. And if there are sperm there in an azoospermic patient, you had your diagnosis. They had a blockage of their ejaculatory ducts. Again, very often due to a cyst or other anatomical issue involving the ducts. So the literature's really blossomed in the last 5 years, I would say, regarding pelvic imaging and MRI. And now we can get really excellent imaging that provides good characterization of cysts, good measurements of the seminal vesicles in a non-invasive way. And I think we've seen a shift. Patients don't like to have transrectal ultrasounds. It's uncomfortable. It's an office procedure. Not to say we can't do it effectively, but if a patient had a choice, most would favor the non-invasive approach with the MRI. And what we found is that actually the anatomical detail is actually a lot better, I personally think, and I think a lot of studies have supported this, with MRI as opposed to truss. And if we do see a midline cyst or other indication to go to the OR, we can handle that procedure there in the OR, transurethral resection of the ejaculatory ducts under an anesthetic, and spare the patient kind of being awake and having the truss probe experience.
Sure. So a few questions just in this, which I think is really, you described it so well. So clinical clues for obstructive azoospermia are azoospermia, low semen volume, acidic semen. Is that correct? Did I summarize that?
That's right. And so the point is that if whenever we see acidic semen, when the pH is less than 7, that means that the seminal vesicle contribution to the semen is not getting through. And that could either be due to absence of the seminal vesicles, as we see in men with congenital bilateral absence of the vas deferens. They're missing the seminal vesicles embryologically. Or it could be due to a blockage of the ejaculatory ducts, as we see in men with prostate cysts. So the seminal vesicles are there, but their alkaline contribution to the semen is just blocked, it can't make it in. And so what's left? The prostate secretions, which are acidic. And so it's going to be low volume acidic pH azoospermia. And, it's a fundamental, concept in evaluating the infertile male.
Great. Second question is, for men with the congenital bilateral absence of the vas deferens, does that by definition mean, can you have that phenomenon occur in the absence of like a CFTR, cystic fibrosis mutation, or do those two go hand in hand? Maybe just tell us about that.
There are rare cases where it occurs outside of an identifiable cystic fibrosis gene mutation, but the high percentage of those men are going to have at least one cystic fibrosis gene mutation. And so keep in mind that patients, who have are homozygous recessive, that have 2 abnormal copies of the CFTR gene, typically will have full-blown cystic fibrosis. Patients who are heterozygous, 1 abnormal copy of the gene, still very often will have some reproductive impact, and that 1 abnormal copy of the gene may lead to them having absence of the vas deferens. So important point there.
And then the last part of it is, let's say you have gone through, you have your pelvic MRI, you've identified what appears to be some type of midlines or some type of cystic structure contributing to obstruction with dilated seminal vesicles. Talk to us. Is this a TUR of the ejaculatory duct? What's the therapy for this? And maybe I'm oversimplifying it, but how do you would then address that scenario?
Yeah, you're not oversimplifying it at all. There's an obstruction there. And so, so we do a TUR of the ejaculatory duct. And so, the cystic structure might be a prostate utricle cyst, which very often midline, really localized to the utricle, and that cyst is causing obstruction of the ejaculatory duct. And usually on cystoscopy, that's really, really clear, really evident. What can be a little bit more tricky, and again, this is where imaging and MRI imaging is helpful, is sometimes we have Mullerian duct cysts, which are cystic structures, again, in the prostate, remnants of the Mullerian duct, which, remember, those are the embryological precursors of female anatomy. Well, they regress in men, but they may still persist a little bit. And those cystic structures can, again, cause a blockage of the ejaculatory duct. So this will not always be so apparent looking in cystoscopically. And this is, again, where MRI imaging can be really helpful to map things out. Now, you can see these on truss, but it can be a little bit more tricky. So I think, again, this is an instance where MRI imaging really shines.
Yeah, that's great. So maybe in the last 5-6 minutes, let's sort of turn our focus a little bit to probably another scenario that even if you're not immersed in a heavy infertility practice, you may come across this, which is these couples that have recurrent pregnancy loss. And maybe you could tell us, like, what exactly does that, like, what is recurrent pregnancy loss, or what is multiple pregnancy loss? But then, should that be cluing us into evaluation of the male patient, and what should that be cluing us into? So maybe talk to us about that a little bit.
Yeah, recurrent pregnancy loss is devastating for couples. It's a real medical roller coaster for them. They get pregnant, pregnancy is going along, they're celebrating, and then boom, they lose the pregnancy. And so for the longest time, really, the burden has fallen on the female partner. And yes, there certainly can be female causes of recurrent pregnancy loss. Sometimes there can be anatomical issues where there may be fibroids or septa in the uterus that can just, prevent a pregnancy from mounting and ongoing. There can also be immunological issues or infection in the female that can also cause these issues with recurrent pregnancy loss. But we now know on the male side of the equation that there can also be issues on the male side as well. Among these are karyotype abnormalities in the male partner, which can, result in an imbalance of chromosomes in an individual sperm. That imbalanced chromosomes can result in a pregnancy occurring, but just as the embryo is developing, the embryo, is just unable to sustain ongoing development, and the pregnancy is lost. Also, in the male partner, the male may have elevated levels of sperm DNA damage, and I think that even urologists that aren't doing much fertility work, you're going to hear this more and more, because this is really a concept that's emerging, has pretty solid literature behind it, when we see that the measurable level of sperm DNA fragmentation goes above 30%, that's when we start to see a pretty clear signal that the couple is at increased risk for pregnancy loss. And I just want to talk a minute about sperm DNA damage. So, in the process of developing sperm, the DNA is tightly compacted down so it can fit in the head in a very tight space. The body actually creates nicks in the DNA to enable the folding and compaction of the sperm. The body then corrects those DNA nicks or damage typically. Some of them can persist though. Also, as the sperm exit the testicle and travel through the epididymis, free radicals in the body can cause nicks or breaks in the sperm DNA. So the whole point is when the level of sperm DNA damage or fragmentation rises above 30%, that's where we start to see a pretty clear signal for just an inability in many couples to maintain an ongoing pregnancy. And so we can check for both these issues, karyotype abnormalities with a karyotype test, it's a blood test, and for sperm DNA damage with a variety of different tests that are commercially available. We use one, a sperm DNA fragmentation test that's available from a particular lab. There are many good labs available that do this testing. But the point is that the male can be a contributor to recurrent pregnancy loss. And we just need to keep that in mind and be able to offer our patients these simple tests. I think if I just say a couple of stats to take away, if a couple has 2 pregnancy losses, they've got a 25% chance of a loss on the next pregnancy. And if they've had 3 consecutive pregnancies with loss, they got a 50% chance of loss with the next pregnancy. So we owe it to our couples to step up and do the workup.
So what are some of the, maybe I would say, proactive measures that could be done? And maybe that is medical, maybe that is surgical / pharmacological. Talk to us a little bit about that. Is there anything that can be done that maybe could help in this scenario?
So for karyotype abnormalities, those are fixed. There's not a lot that we can do for those, but if a couple is going through IVF, couples can actually test and select embryos that do not have karyotype abnormalities present. So that is how that is handled, karyotype abnormalities. In terms of sperm DNA damage, there are things that can be done. So first of all, just over time, there's natural variation in these numbers for some patients. So certainly sometimes we can catch a window where a patient's DNA fragmentation returns to a more normal level and their risk of pregnancy loss is going to be lower. Medically, the utility of providing antioxidants is something there's really not a lot of strong literature to support their use, but it is something that practically is low cost and low risk. So we do it with the thought that we're going to scavenge excess free radicals and perhaps avoid sperm DNA damage. Men who have varicoceles, this can be an indication to fix varicoceles. Varicoceles are associated with an increased level of sperm DNA fragmentation. So that is sometimes an intervention that can help. In the laboratory, the lab can actually use sperm processing mechanisms, especially using fluid dynamics, where sperm can be segregated into 2 populations, including an enriched population with lower levels of sperm DNA fragmentation. And finally, last but not least, and we point this out in the guidelines, going to the testicle, going upstream of the epididymis and getting testicular sperm is also an opportunity. And there's good literature to support use of testicular sperm in these couples. And that testicular sperm seems to have improved outcomes over ejaculated sperm with high DNA fragmentation levels.
So what you're saying is that if you have a male who seems to consistently have high DNA fragmentation levels over that 30% threshold that you were describing, that one of the considerations is, I guess, almost to go more proximal and to do testicular harvesting. Is that correct? Did I understand that correctly?
Yes, that's correct. And one other important point I do need to mention as well is this emerging concept of rapid or frequent ejaculation protocols that Dr. Schlegel, among others, have really published on very recently. And And there's a notion there that, frequent ejaculation may, in essence, diminish that epididymal transit time or get sperm that's, had less of an opportunity to be exposed to this environment in which the sperm DNA fragmentation occurs. So rapid ejaculation, then also, yes, going upstream of the epididymis is also a method, and we do comment on in this guidelines as being an acceptable method to approach these couples with recurrent pregnancy loss and high DNA fragmentation levels.
Great. Well, Bob, really appreciate it. That was really a great coverage of, I think, not only some of the changes in the amendment, but I really think allowing me to sort of pick your brain on, I think, some of the bread and butter stuff that I think that even if you're not immersed maybe as a specialist in this field, what I think almost all of us may see in general practice. And I thought you did a fabulous job in really bringing all aspects of the basic all the way to sort of the more nuanced evaluation there. So I really do thank you very much and appreciate very much your time.
Just also want to thank, the AUA, the Office of Education, the Practice Guidelines Committee, Senate Kim, Corey Tanner, colleagues who, worked hard on these. And I just want to thank the AUA for providing us with really substantive roadmaps. And I think that this guideline document provides that for our colleagues who are providing couples care for infertility.
To our listeners, thank you very much for joining us today. For more information, please visit us at auanet.org/university. And certainly we will have tagged to this podcast the full guideline. So if you want to read in greater detail any of the elements that Dr. Brannigan has walked us through over the last half hour or so, you could certainly do so and look at some of maybe the Sentinel articles and some of the tables that he's discussed to appreciate some of the changes. Bob, always, it's good seeing you. I look forward to seeing you again in person next month. And once again, thanks so much for your time.
Thanks so much, Jay. I really appreciate it.